Renu, how are you?
Hello, Declan. I'm good, thank you. How are you?
I'm good. Nice to have some good guests in studio.
We have a full studio today. It's very exciting.
So we've called this one the ABC of mHSPC.
Enough acronyms in there.
I was trying to come up with some kind of intriguing way of talking about,
Good. I like it.
metastatic
ABCs
prostate
of
cancer.
mHSPC.
Yeah, I don't know. So we've got two great guests in the studio on this episode of GU Cast. It's great to welcome back two friends of the podcast. We have Professor Andrew Weickhardt from Austin Health here in Melbourne. Andrew, thanks for popping back in.
Thanks for having me.
No
I think
problem.
last time, Andrew, you were in this seat. Do you remember?
I do. You were
I was
away,
all the
and
way
I
in
was
India,
occupying the
that's
hot
right.
seat. Yeah.
Oh, that's right. He was. I forgot about
He
that.
was your co-host.
Yeah, and you were on the screen.
I was
dialing
on the
in from
screen.
India.
Yeah, that's right.
And Professor Fred Saad from Montreal. Welcome back to the podcast, Fred.
It's always a pleasure being here with you two.
It's great to have you here, Fred, and first time in the studio.
Yeah, this is great. Very impressive.
Do you like it?
I love it.
Because he was, I remember very distinctly, our first kind of international visitor to come back to Melbourne in 2022. It was like second half of 2022. We've been shut down for years with COVID. And then finally, an international visitor came.
Yes, yeah. So
just
it was a
opened
very
up the-
exciting time.
Yeah. And we all turned up in downtown to listen to you talk. And we recorded a podcast. So 3 years later, we'll see what's changed.
That's right. Let's see.
So the ABC of mHSPC.
Yeah.
So
We've covered mHSPC quite a bit now, but
Yeah.
I think these ABCs are important points.
okay, so I'll try and remember
Okay.
what
Do
they
you
were.
remember?
So ARPIs. Okay, we're going to get it out of the way. We're going to pick the brains of Andrew and Fred about ARPIs in mHSPC in 2025. Who, when, how, which one, etc.
Yeah.
How do you the practical things? We'll kind of presume it's a gimme that hopefully everyone knows that we should be adding an ARPI to the vast majority of patients who are starting on ADT. But ARPIs, we're going to talk about
So
ARPIs.
A is not just ADT alone, it's adding ADT.
Exactly. We're presuming
Adding
the ADT. The second one is B is for break time, because I'm semi-obsessed with this idea that now we're in the doublet ARPI era. There's a whole bunch of patients who, in the old days, if they were on ADT alone, might be having a break. They might be on intermittent ADT, because intermittent ADT is a thing we've done for years and years for lots of men with, maybe relatively low volume, recurrent disease, for example. The PSA goes right down after a year to have a break from the ADT. So I'm fascinated to know what Fred and Andrew think about the idea of intermittent hormonal therapy in the doublet era. Because there are trials going on in this space, but now we've been running these patients for a couple of years on doublets. The PSA is wiped out. They're going great. But can we give them a break? Do we have to wait for 10 years for a trial to read out? Or what about break time? So that's the B.
Yep.
C? What was C again?
C is special for Andrew.
Oh, yeah. Oh, chemotherapy. How could I forget the historic role of docetaxel chemotherapy? For younger listeners out there, we used to give chemotherapy for mHSPC. And they're both looking at me now, Renu. I'm in trouble already.
We should still be giving
Oh,
chemotherapy.
here we go. Already. So wait for that. Stay tuned for part C of the ABC of mHSPC when we talk about the role of chemo up front. So how do you think that sounds, Andrew? The menu for this podcast?
Good. Yes.
Yes.
You could have added a D for docetaxel.
Oh yeah, we could have gone all the way to R for radiotherapy. I was trying to figure out a way to put radiotherapy in there, but the D for docetaxel, C and D together equals E. E for expletive. Renu. So what do you think ARPIs in 2025? We got like 6 or 7 minutes to talk about ARPIs. What do we want to?
Yeah, I think the important point is that the standard of care for mHSPC has definitely changed.
Yeah.
And now it's no longer ADT alone like we used to do many, many years ago. The way to give systemic therapy in mHSPC is at least a doublet.
Yeah.
So I think that's the important message.
Fred, over to you.
Across.
No, I couldn't agree anymore. I think the new ADT is ADT and ARPI. And if you don't think they needed an ARPI, maybe you should question if they need ADT at all.
Yes, good point.
So really, if you're on the fence, maybe just not give anything and leave the poor patient alone from all the adverse events of ADT. And if they are destined to suffer and eventually die of prostate cancer, then you have to do the very best. And the very best is at least ADT and ARPI. And we'll come back to this chemo question.
In part C.
Yeah.
I think so. It's a pretty simple message. And we'll get into which ARPIs, how do you choose, DDIs and all that. But Andrew, in 2025 in Australia and in many countries, the ARPIs are there now. They're reimbursed and available. So it's
I think we're blessed by choice of 4 different agents, which are commonly used in most healthcare settings at the moment. And, I'm interested in, Fred, like, how do you choose which one to use with your particular patients that you see?
Yeah. I think, like you said, we're blessed that we have multiple choices. So for many patients, we can find the one that would be appropriate. Gladly, for the majority, all 4 are appropriate. Now, maybe I'll take your question from the other way around. Which one I would use the least? And that would be abiraterone and prednisone. In the era where that's all we had, I think it was acceptable to give a drug that you had to follow potassium levels, hepatic problems, and give prednisone. In an era where we have other choices, I would rather avoid having all these metabolic issues and having to deal with prednisone, especially in mHSPC, where patients are going to be on for not 10 or 11 months like for mCRPC, but for 2, 3, 5, 10 years if they're doing well. So there are issues that I would rather avoid if I have alternatives. And we do have alternatives. So abiraterone is almost never used in my practice for patients with mHSPC.
Yeah.
Yeah, that's a good point.
So-
I mean, you say we're blessed for choice, but sometimes it can be a curse as well. And I think that's where a lot of urologists especially get stumped. There are these 3 ARPIs out there that can be used. How do you find the one that fits best for that patient, that fits in with the other medications that patient is taking? How do you follow up these patients? So it seems like there's a lot of information to take in, and it changes your patient interaction. Whereas ADT, that was easy.
Actually, that gives me the excuse to play the clip, Renu, that we pulled out of the podcast that Fred recorded when he was last here in 2022. So he gave us this memorable soundbite that I'll play back to you, Fred, and see, does this still ring true today when you were talking about the management of mHSPC and these sorts of choices?
But you should not dabble in metastatic prostate cancer. I don't think people dabble in metastatic breast cancer. It would be a crime. Why is it okay to dabble and just treat a metastatic prostate cancer once a month or once every couple of months because you don't see it very often? It's become unacceptable. Prostate cancer has become much more complicated than when I started 30 years ago. And we have to just either get on the bandwagon or work with others that are really comfortable with all that there is to offer. It's unacceptable today to just say, I do a little bit of this and a little bit of that, and I dabble in metastatic prostate cancer once in a while. That's unacceptable today.
Don't dabble. What do you think?
In between my stone patients, I'll just treat the occasional mHSPC patient.
And there are dabblers out there listening to this podcast. And so we can turn dabblers into semi-experts at least, Fred. So, yeah.
What we want is to get the dabblers to become referrals.
Yeah.
Refer to people who are really dedicated. And it hasn't gotten any easier over the last 3 years. It's actually gotten more complicated. We've got more and more options. We've got to think of sequencing. We've got to make sure that patients are going to the next treatment when it's most appropriate before it's too late, falling apart and not having the opportunity of either going to chemotherapy, lutetium. There are multiple options, and there are clinical trials that are still going on.
Yeah.
Do you have a problem with dabblers, Andrew?
Well, I think the complexity of the drugs we have at the moment is some of the drug-drug interactions and the patient population that we look after. It's pretty common to have cardiovascular medications that would make sense to review and make sure that you're not either decreasing the effectiveness of their thrombotic therapy or actually increasing the statin dose by a factor of 4, which occurs with darolutamide. And so I think that you've got to ensure that you know the medications, the common side effects, and how to manage them. And you've got to understand about how to review and assess the patient for side effects. Because although most patients can tolerate whichever drug you give pretty well, I think we have to understand that they do have side effects that can occur, need regular review, and you need to monitor for complications over the longer term too, like bone health and cardiovascular health. And I think the dabblers, they're at risk of ignoring those other critical areas.
Yeah.
And it's a team effort.
Yeah.
I mean, dabblers usually don't have this structure around, and it's a team effort. It's never just one person. There are nurses, there are radiation therapists, there are medical oncologists. There's a whole team around optimizing care.
Yeah.
And that's important.
And it's important to develop that team if you're interested in treating these patients with mHSPC, because not only does it make it much easier for yourself, but it's so much more beneficial for the patients. I wanted to ask about dose reduction, Fred, because that's a common way of managing a lot of the side effects and toxicities of the drug. Do you think it reduces the benefit of the ARPI when you dose reduce?
It's a really good question. Personally, when you dose reduce because of real adverse events, I think that the efficacy is remaining relatively good. Mm-hmm. There's always a bias, but when we're looking at patients who had dose reductions, we're not seeing worse outcome as if the PK of the drug might be just too high for that patient. But it's an open question, and I would rather continue with full dose and not take the risk of maybe having less efficacious results by dose reduction or dose interruptions. Yeah. What you'd like is to continue maximum dose, not ever having to stop because of adverse events.
And Andrew, is that something you do often? And how does dose reduction help to manage toxicity and comparing that to benefit?
Yeah, so in the setting of a patient that has significant toxicity, I always give patients a 2-week break to feel that I understand whether it is actually the ARPI. I mean, sometimes patients on ADT feel terrible fatigue. So stopping the ARPI doesn't improve that, right? So 2 weeks off, a dose reduction of 1 level. So often it's 1 tablet less. And then I'd review the patient. And if they have persistent toxicity, which I think is directly linked, because when they've restarted after some improvement, that comes back. And let's assume we're not talking about hot sweats, which we can now, manage a bit better with some different drugs. But, with significant fatigue and so forth, I might consider, rather than reducing to sort of 50% or even less, I might occasionally rotate that patient to a different ARPI after another, 2 to 4 weeks off. Yep. But, we might come to intermittent treatment as a strategy as well. For some patients who have lower volume disease, if they hit a wall of toxicity, I think it's important to review the patient's biology and say, does this patient need continuous ADT for, eternity, or can they have a break?
So Renu, I think Fred's comment is the one that rings with me when you first asked the question, is that, we want the dabblers to refer. So maybe that's part of the message. You either, don't dabble and refer, or, what we're trying to do is grow the pool of people who are feeling confident and competent at managing mHSPC in the ARPI era, and because some of us who've a big personal interest in this have been able to skill ourselves up to be able to sort of, do this safely. So I think that's the message, though. The dabbling has to stop, because the dabbling's in nobody's interest. So you either take an interest or grow someone in your practice or your clinic, build that team around you so that you can make really good choices about ARPIs. But the problem we had 3 years ago, Fred, which you also talked about on the podcast, is all the people who are still on ADT monotherapy when they could have access to intensification. It's not eradicated, but hopefully in 2025, it's less of an issue out there. So now we're more in the implementation of, make sure you are picking the correct drug and so on, and supporting the patient then in assessing their response.
Absolutely.
A, done. B, okay, what was B? Break time. So Andrew, this is something that we're now seeing because we're sort of 2 years into the fully reimbursed ARPI era here in Australia. So, and especially in a PET imaging era, we have these patients with recurrent disease. You do a PET scan, the PSA is 4, they got quite bulky retroperitoneal disease. They're M1A, the sort of stuff that milks away with probably ADT on its own, to be honest. But they've enough there to say it's a mHSPC patient, he's fit, he's got this burden of disease, PSA is going up quickly, I'm going to start ADT and an ARPI. But now, 1 year, 2 years later, we have these patients whose PSA is wiped out. Fantastic response, and they're going to go for a long time with this, and they have some symptoms. We'll say, what's your approach to these? Can we apply the old criteria for intermittent ADT to patients who are on ADT and an ARPI without trials to say it's okay to stop?
Yeah, I think it's a great question to ask, because I think it's important to realize that strategy of intermittent ADT has been used for many years by mostly urologists that looked after this group of men. And there's a group of patients with especially recurrent, low volume, non-metastatic prostate cancer by conventional imaging that we're now seeing with PSMA-defined metastatic disease. And I actually like an intermittent strategy but it's important to note that's not guided well by current clinical trials. And while some are underway, we have some to look back on and try and learn lessons from. And, if you think about the SWOG study, that used intermittent ADT, published in 2013, and the controversy still there regarding the not being non-inferior in terms of overall survival. Now, people who recommend continuous ADT, I think they overlook the fact from that SWOG study is the median PSA of the patients going on was 41. 28% of patients had painful bone metastasis when they went on study. And the time that patients had their ADT recommenced was either when it was above 20 or when it was at a level that it was similar to when they started on treatment. Now, I don't think that's actually what we do in practice.
Yeah.
And I feel that a practice of discussing with patients that there's some uncertainty, but overall for patients with lower volume disease and recurrent nodal metastatic disease on PSMA PET, I feel comfortable with that strategy.
Having that discussion and supporting a patient if they say, I'm quite happy to take a break, And we're forgetting about maybe local challenges with the reimbursement and what the local body might say about that. But Fred, what's your approach on these patients?
No, I share that completely. And the patient you're describing who is non-metastatic on conventional and metastatic on PSMA is actually PR7, is the recurrent patient that's non-metastatic. If we had done PSMA PETs in those patients, probably a good proportion would have been metastatic. And the other thing that we didn't know when we designed PR7 and PR8 is that stopping ADT, you just had to go below 4. We would never do that today. You would never stop ADT until you were at undetectable. But the criteria to stop ADT was just to get below 4. That's all it required. And so we would never do that today. And we would never not restart ADT if PSA was going up with a castrate testosterone, which means castration resistance. We weren't following testosterone. We learned a lot from those studies. So we can do a much better job of intermittent today than we did 20 years ago when we designed those 2 studies of intermittent versus continuous. And I'm sure intermittent would have actually been not only non-inferior, maybe even superior in terms of quality of life and many other endpoints.
And now you're talking about some of these patients that you're picking up on a PET scan with a PSA of 0.7 and some retroperitoneal nodes. I mean, they're going to live for 15 or 20 years of treatment ahead of you. If you're starting ADT, there's all sorts of issues about starting treatment too early. Fred, right?
But there does seem to be a clear population in whom you would consider intermittent therapy. It's not the really high risk, high volume patient who has an exceptional response to doublet therapy. I mean, these are patients you want to keep going because you want them to stay for as long as possible in the mHSPC disease status. But in those other patients, who are, like you said, Declan, who are going to live 15, 20 years with this.
So I'm feeling that the group are thinking, intermittent, we can apply some of the data. But if we're there'll be people listening, Fred, who will say, nope, that's not right. That you risk, you under-treating these patients by stopping and it's not safe, etc. But by the time Libertas and other trials read out,
and when we did the trials, it was only 8 months induction. I think now in a metastatic, even low volume metastatic, I think we wouldn't go below 2 years before I would consider stopping. I mean, we give 2 years with high risk localized disease with radiation therapy. I would give at least 2 years before having that discussion. And the discussion for now comes from the patient. Can I stop? I'd like to take a break. This is a shared decision, and I want the onus to be on the patient who is wanting to discuss this stopping approach.
So do you ever introduce the topic of a treatment break to patients, or do you wait for them to...
I tell them that every 3-4 months when we have this discussion, I said, we'll talk about this. The data is accumulating, and this is a discussion that needs to be frank, but it's mainly patients talking about, can I take a break, and saying, and we're going to do better intermittent than when we did ADT alone. I mean, this is and Embark is a really nice proof of principle because PSMA PET wasn't done in Embark. But if you did the same patient population, rapid doubling time, elevated PSA, a large proportion have actually exactly what you described of metastatic disease on PSMA. So I think we do have some proof of principle that it's safe and effective.
Totally agree with you. And I'm glad you said, because I think that's one of the nice things about Embark is they built in stopping. If your PSA is right down at 9 months, you can stop. And, I just feel that, if we insist on waiting for the current trials of stopping to mature, the mHSPC trials, that'll be like a huge amount of men who have probably been way overtreated. And I personally, if I'm the patient, Fred, and one of you gents or lady is having that discussion with me, I'm happy to stop. I've got metastatic hormone sensitive prostate cancer. I've got relatively low volume disease. I'll be on and off treatment and hopefully I'll live for very many years. I'm quite happy to take the foot off the gas for a while, go back on for a while while you wait for the trials. Or even better, of course, go in a trial. Yeah. But I just feel, but I've had this discussion, Andrew, at meetings where people are sort of, nope, that's not right to do that. It is incorrect. It's not quite unethical, but you should not do that. But I don't know. I think some of those discussions come from people who don't have the experience of using intermittent ADT because this is medical oncologists who didn't look after that group of patients post radiation PRO7 with rising PSAs
I mean, I think the scary thing is that in a lot of these patients where you stop treatment, their testosterone levels never recover. So that occurs in about 30-40% of patients. Yeah. So I think in those patients who are going to live a long time and are going to go on and off treatment, I think we have to take it one step further and say, well, is there a role for some cautious testosterone replacement therapy in these patients?
And we've had that discussion in patients that are doing very well off therapy. But this is something that we need to continue to work on. And the patients have a word to say. We have a responsibility of discussing these things with the patients and saying, look, we don't know. There's a bit of a risk, but there's also an advantage.
And we don't know either what the optimal intermittent strategy looks like in terms of, is it monotherapy ADT to continue? Yeah. Is it monotherapy, stopping both? Could you just go on monotherapy ARPI at a point in time? Does that have any benefits? And we don't actually have any good biomarkers or set points to actually guide us. So ideally, some of these trials, which you've alluded to, might help answer that. But I think the intuition of experience and learning from people that have treated these type of patients with lower volume and their long lifespans, I think that guides my decision-making at the moment.
And I think also the restarting trigger, because you're talking about people with a PSA of less than 0.1 or 2, in this era, and 2 years later, that's what it is. And okay, we're going to stop you. And what's the trigger for restarting? You'll sometimes find, well, they were started when the PSA was 1.3 with a positive PET scan, whereas in a different world, you might not have started that ADT or any sort of treatment at all. So you think, well, now it's gone back up to 0.9. I said, well, we might let it go to 4 or 8, or let's see what a CT scan, God forbid, shows, etc. So we don't have the trials to guide that, but intuition. What does the patient think, Fred?
Yeah, but that's a really important point. When to restart, and this is where you have to be obsessed with testosterone. I mean, if a PSA is at 2.02, you would say, "Oh, it's 2. That could be a bad sign, or could be very secure." But if the testosterone hasn't recovered, like you say, Renu, and it's at 2. He's actually castration resistant, even though he's off therapy. And so you really have to be looking closely at, and my trigger to restart is much lower if testosterone hasn't completely recovered. So, even a PSA of 0.9, if testosterone is really castrate, he's going towards castration resistant. I'm going to restart very quickly if he's at 1.5, 1.6, and his PSA is starting to rise. That's the first signal. So I wouldn't wait any longer. That's the patient that needs to be on then continuously.
That's one for the dabblers. Take that point, you have to look at what's happening. Because it might be nothing to do with the fact you did stop that treatment. He's actually castration resistant because the testosterone is low. Yeah. Now, the dog is barking outside Renu, which means we must be about to talk about chemo. He gets upset. He gets upset about that.
He does get upset.
Hamish,
it's rubbed off, yeah.
I'm
a bit worried about what Fred's going to say here.
I know. I thought he was on our side.
Fred
I thought
is
we were just getting up on Andrew.
Yeah.
But he has decades of experience giving docetaxel himself in Canada. C is for chemo, Andrew. So as you know, I have this ridiculously dug in opinion over the years of that there's no role for chemo in mHSPC in the ARPI era. Tell me how wrong I am. What is the role for chemo in the era? Let's presume now this is with ARPIs being available for your patient, and you've started the patient on an ARPI. So we're really talking about triplet, but adding in the chemo.
Sure. So I think it's important to acknowledge that we've moved from an era of chartered and stampede where we were giving docetaxel chemotherapy with ADT to the majority of patients, and then there was a bit of finesse to those with high volume disease. The trials that have used ADT plus docetaxel plus ARPIs, those trials, so you have Arasens, and you also have the study where you've combined ADT and docetaxel as the standard of care, and you've compared adding the ARPI. And your point has always been, that doesn't prove that adding docetaxel improves overall survival. But I think there are some clear scenarios that now with finesse we can look at that, and without using the overall survival, the absence of that, we can make some pretty sensible decisions. And look, you as a practicing urologist, often use technology or techniques that don't have an overall survival benefit, and we could go through those now.
Or have a lot of evidence backing it up.
Robotic surgery has.
I'll get
that hurt. Yeah.
Coming up to the end of the podcast now.
So I think
we can edit this out, right?
Experts in the area would then look at how to break it down without that overall survival advantage. And so I think the clear patients that I see these days are those patients with de novo metastatic disease who have liver metastasis or marrow infiltration. And we occasionally see those patients that come with, low platelets, anemic, and a heavy burden of bone metastasis. Now, I believe those patients, if they're fit, they should receive triplet therapy. Now, there's a second group that I look after of patients with high volume bone metastasis and de novo metastatic disease that don't fit that sort of liver metastasis kind of picture, but those are patients that have painful metastasis. They have a high ALP that's, shown to correlate with poor prognosis. Lytic metastasis on a bone scan, and some of the patients that present with an ultra low PSA but a burden of metastatic disease that's out of keeping with that. Now, all of those patients, you want to try and make sure you've excluded small cell transformation. But in that group of patients, I think it's very valid to have a discussion with fit patients and say, docetaxel chemotherapy is probably going to lead to a significant rapid improvement in control of your disease over and above doublet therapy alone. It may not be associated with an overall survival benefit we can prove at this point in time, and there are some side effects like neuropathy and decreased quality of life temporarily. And in my view, I think that group of patients probably are best served by consideration and discussion of docetaxel as an option. But it's not every patient that I use docetaxel on. And so it's really refining that patient population. What do you do, Fred?
Very good.
Well, I thought I was listening to myself speak. So that was very nice. That was very nicely put. But, if I can sum up what was just said, if I believe the patient has clones that are less hormone sensitive, I need to give something that's not hormonally driven therapy. It comes down to that. And you described those scenarios extremely well. Liver metastases, low PSAs, very high burden of disease. When you look at the androgen receptor, the higher the burden of disease, the more likely you're going to find deficiencies or alterations of the androgen receptor. It's a volume dependent scenario. So if you give it to a low volume patient, only lymph node mets or a few bone mets, I think hormonally based approach is going to be by far more than enough for the majority of patients, and we'll probably come to maybe taking a break.
Yeah.
But some very young patients we've treated with triplet therapy that had low volume disease, I want to give them the very best chance of getting rid of these clones that are going to kill them down the road. And you talked about breaks. I'd rather give them quadruple therapy, quintuple therapy one day, and really try to cure that cancer. And we're getting close. Triplet, I think, is just the first approach to try to get all the clones to die. And then after a couple of years, say, that's it. No more ADT, no more treatment, and live off being castrate for the rest of your life. That's my objective, is that we stop this, ADT works well with an ARPI for the rest of your life. What man wants to stay castrate all their life? If you can do something. We're the only solid tumor that keeps treatment going on forever. All the other solid tumors try to take a really rational, aggressive approach. Hodgkin's disease, and a lot of other diseases are going to get treatment, even in combination with some radiation or whatever, and try to really cure that patient of their disease.
Wow.
Should have picked a different seat.
No, it's not for everybody, but there is a role.
So I guess my question is, I mean, you make a compelling argument, but when we don't have the evidence of a survival benefit for triplet therapy over doublet therapy, do we have anything to lose by starting a patient on doublet therapy and seeing their response?
And then try and convince them to have chemo.
And then,
Right.
and if it's not an exceptional rapid response, then you add in the chemotherapy. I mean, does that make sense? I mean, but what you're saying makes a lot of sense.
Dynamic biomarkers such as the extent of PSMA expression at 3 months or detectable ctDNA levels or lack of suppression of PSA by 3 months or 6 months, all of that, I think it should be studied because I think they could actually be quite useful in the scenario that you're talking about, trying to work out, does this patient have adequate rapid suppression, or do they have a very poor decreasing PSA, still a burden of metastasis that are visible on PSMA PET? And, other genetic biomarkers like RB1 and P53 and loss of P10, all of those could also be incorporated to guide decision-making, and ideally trials would help guide that.
Yeah, and I like that approach more than just the PSA approach. I'm concerned that if you say, well, wait 6 months and see what the PSA is doing and then decide to add the chemo, I really believe there is some synergy in trying to kill off the cancer early. And I'm worried about the cancer cells that actually need docetaxel are not the ones really producing the PSA, right? We're looking at what are androgen-independent clones that need some other mechanism of action. So I think it's a very rational approach, but I am concerned that maybe we're going to miss the boat by saying we'll wait 6 months, 9 months, then add the chemo and expect miracles. Because if they're not responding well, they're actually showing signs of ARPI resistance. And chemo is not great in the ARPI resistant setting. That's what we see when we give it post-ARPI. So I think, we can probably wait a little bit. We never start anyways right away. We start at least a couple of months after the ADT, because you get more toxicity if you start too early. But I think we'll have to wait for some of the trials and see what they do. But I really prefer looking for signals that you really need a non-hormonal approach, like an RB, P53, others that we're going to develop.
So well, these erudite gentlemen have made a very compelling talk, and they have identified. You're right. I think you start off by saying the gut instinct patient. You're right, and then you've kind of segued on to say, but actually we can use some tools that are increasingly available to help identify that patient with your gut instinct, and they'll align. But I suppose what I'd say to you is that, well, here in Australia, I think that means probably vast majority of mHSPC of new ADT starts in this country, I reckon, don't fit that. Yeah, so they're going to do really well with ADT and ARPI. So,
and to Fred's point, when we're talking about bringing treatments like lutetium PSMA earlier and earlier in the disease spectrum, and now we've got the upfront PSMA trial that shows efficacy in the hormone-sensitive prostate cancer, there are still going to be those patients who have those abnormal clones that need chemotherapy, aren't there? Even if lutetium is approved.
Yeah, and you are the country leading the world in imaging. And I'd like to use imaging as a biomarker, right? If you have PSMA positive disease, which is what you would expect for somebody who's going to respond to hormonal, but why not combine it with FDG? If you've got lesions that are FDG positive, they're not going to do well on a hormonally based approach. And you might be able to just have something that's low hanging fruit to help us decide who needs what. Why not do those kind of trials that are more intelligent than just saying base it on PSA?
If we were getting to E, Andrew, we would have talked about ENZA-P a bit, because it's not mHSPC. But when we had you in the studio, when ENZA-P read out at ASCO GU, that provoked a lot of interest, because the idea of starting this poor risk MCRPCs on enzalutamide and then add in the lutetium, spectacular responses, really. So do you think that you could apply some of the similar things? We're going forward a bit to say we'll prime some of these patients with ADT and an ARPI, but then be adding in selectively, whether it's chemotherapy or lutetium, that's the strategy. It'll be driven by identifying those patients and priming them with one thing and then adding in the other thing.
Yeah. And I think trying to get rid of the clones, as Fred was saying, that might be resistant to AI-targeted therapy with lutetium or PARP inhibitor or other combinations up front is where the field's moving. And I think we just are going to need a sensible strategy to look at the balance of trying to improve overall survival while preserving patient quality of life over the longer term, and trying to find those higher risk patients to use the more aggressive treatments. And then, reflecting back on what we've already said, make sure we use the appropriate lower intensity therapies for patients that have a long natural history, regardless of what we do.
ABC, that's the ABC of mHSPC so far. Tune in tomorrow for the DEF.
DEF, maybe G.
I was going to say D could be don't use this dice, which my fellow gave to me. And I'm not sure if you can see that, but it's got treatment options for the patient that presents to you with metastatic hormone-sensitive prostate cancer. So we could roll the dice, and that's got adding Yonsa or abiraterone.
Yeah.
You're kidding me.
No, because he was making fun of me in clinic, saying he couldn't quite follow my decision-making on which patient got this. So this was from my talented fellow AJ, and
there it is.
So, there's different options on each of those where you can see.
And there's triplet there.
Yeah, triplet therapy. So,
Radical prostatectomy.
Why let science get in the way of a dice?
Absolutely. That's great.
It was a great present from AJ. And I don't use this to make my decisions. I want to reassure any patients listening, I don't use a dice.
Rolling the dice.
If you had a patient with a really good sense of humour, you could pull that out of your pocket and say, I'm going to determine your treatment now.
Yeah.
Well, as we were talking before we started the podcast, or use ChatGPT to plug it in, and maybe you should just roll the dice on it. But there you go,
Well,
Renu.
that was a great chat.
That was a great chat. Now, we do have to leave because you and these two gentlemen are educating us tonight at a dinner here in the city. Fred's visiting speaker at this Limbic event we have tonight, and Andrew's speaking, and you're the chairperson.
Yeah, we're looking forward to
so we
it.
got to finish up and head down and enjoy dinner. But thanks very much, Fred and Andrew, for coming back in and speaking to us. It's been really entertaining and edutaining, as we say. I've learned a bit.
Perfect. Thank you.
Excellent.
And that's all we have time for on this episode of GUcast. We'll be back very soon again. Thank you.
See you next time.